So we're now moving into our liver panel discussion. We've got Dr. Vidal-Jove again up here leading this session, and panelists joining us live and online. So I'll let you guys get started.
Well, hello everybody. Here we are again talking about the liver. Before I introduce our panel, I want to also mention that there have been two presentations. One is Tejas Worlikar, the group of Senshu that is joining us here also as a panelist, with the presentation Isotrypsin inhibits development of liver metastasis in rodent. It's an excellent presentation, and we will like to comment a lot about this. And then Ali Bashir from the School of Medicine at UCLA, diagnostic accuracy of contrast-enhanced ultrasound in detection of hepatocellular carcinoma. Okay, so now we are going to present our panel. We have Senshu, which is joining us remote from the Biomedical Engineering of University of Michigan. Anything to say, Sen?
Hi, everyone. Sorry that I cannot be there in person. As Dr. Vidal-Jove is saying, so I'm the head of the historypsy group at the University of Michigan. And, we're doing both preclinical and some clinical work on the historypsy liver tumor treatment. So glad to be here and share with everyone. Thank you.
Thank you. And joining us here, present, Eli Blasilavich from the University of Virginia Polytechnical, Biomedical Engineering. Eli?
Yeah, great to be here as well. My work also focuses on histotripsy for the development of liver tumor ablation and other applications, and very excited to be a part of the panel.
Joining us also virtually, Michelle Meniratalala from the University of Michigan also, Clinical Associate Professor of Radiology. Michelle?
Hi, thank you again for the invitation. Sorry I can't be there in person to join you. I work closely with Jen, started working in her preclinical lab, and I am running the clinical trial, Hope for Liver, here at the University of Michigan.
Thank you. And also joining us virtually, Kathy Ferrara from Stanford University, Professor of Radiology and Molecular Imaging. Kathy?
Hi, I'm Kathy Ferrara. I am a professor of radiology with a lot of background in ultrasound in various ways, and also division chief for the molecular imaging program at Stanford. So I do a variety of things as a part of that program. We've primarily been working in pancreatic and breast cancer, but we also have a project in liver cancer that involves microbubbles and transfection, and have been looking at the use of gene delivery in liver as well. So, and that is all preclinical work in that particular case. Thank you.
Thank you. And a very brief introduction of the field. As we have here, also from the data of the Focus Ultrasound Foundation, we have that the liver tumors are probably the most represented in terms of mechanisms of action, and sites that are doing treatments, 182 centers that do treatments on liver tumors. We also see that the treatments by indication cumulative, but in the last year have been important. We've done treatments of a lot of patients, and the percentage in terms of indication on oncological treatments is 43%. So it means that almost half of the treatments that are being done in oncology are on liver tumors. So it makes this field very important and very relevant. Mechanisms of actions that we're using, well, the non-thermal, the hyperthermia, the histotripsy, the thermal ablation, and different ways of treating this. Immunomodulation, tissue destruction, in what is called drug sensitization, drug delivery, etc., etc. So we are going to address different subjects, different issues in what is today the most hot issues on this field. I selected a few papers that for you to watch and to read, and the paper of the group of Sen is going to be very well discussed, and also the recent trial that's been done in histotripsy in liver tumors. So here is our main character, the liver. It's a huge organ. It has a very consistent parenchyma that inside has three vascular systems: the hepatic vein, the arteries, the portal vein, and the ducts. So how to deal with that is one of the things that also we would like to discuss in the coming minutes. So Michelle, this is for you. So the Hope for Liver trials have been recruiting quickly, and I think that you have all of the patients recruited now. The trial is completed or about to be completed. Can you describe us how the trial was gone, and can you share how it works, how it was, the trial?
So, just because we're still kind of in the process of accumulating all our data and going, analyze everything, I can't say too much. I can share a little bit about my personal clinical experience, nothing really related to other cases, as we don't know. So the trial is complete, almost complete. We've treated a total of 46 patients with histotripsy. At University of Michigan, we treated the most patients. We treated 10 patients, 13 tumors. In terms of safety concerns, we've met all of our safety endpoints without any concern. I don't know, that's very brief, I know, but.
And did you see any abscopal effects in your patients?
So of course I'm not allowed to give all that information out, and you heard Tejaswi speak about her research, I think, in this session a little bit earlier. And if you've seen some of the other literature that's come out in our animal models, our small animal models, we have shown some form of abscopal effect. We have the HCC studies, there's some melanoma studies. In terms of in the patients, again, we haven't analyzed all the data longitudinally yet. There are many other sites right now. From my own personal clinical experience, what I can say is that many of the patients that we treated did have diffuse metastatic disease, some of which were non-responders to systemic therapy. And based on this trial, we were only allowed to treat 1 to 3 lesions, certain tumor size less than 3 centimeters, and we had to treat the entire lesion. So unlike, and I don't want to take away from what Jen's going to talk about, but what we spoke about earlier, where we did partial treatment, we had to do complete treatment in the patient on the lesions that we had. So what I can say is, as of right now, all of our patients are still alive. In fact, we just had our first patient have her 1-year follow-up study, and we've got a couple more 1-year patients coming up very shortly. So I can say we are very eager to see the final results and excited for the outcomes, like they were with the Spain trial, but I don't really have more to answer in terms of the abscopal response at this point.
There are also 2 things that the audience is very curious about. It's how do you deal with the ribs, and how do you deal with the motion of breathing?
So all of our cases, let me answer the second one first. We did all of them under general anesthesia for that reason of breathing. So if they're not under general anesthesia, when you're treating a patient, when you're even doing a biopsy on a patient, the patient's breathing, they can breathe erratically or differently, right? So everyone was done under general anesthesia for the purpose of this study. So the breathing was very controlled. I really didn't find any issue with breathing causing any sort of problems with lesion motion too much so that we could not treat it. That was not a problem in any of our cases because it's a very regular breathing. And when we target these lesions, just like if we were to do any form of thermal ablation or any form of treatment, we would want a safety margin around our treated tumor. So in keeping with that safety margin, the breathing really did not create any issue, and we achieved technical success in all of our patients in terms of what our target volume was going to be. So I think that doing it under general helps. In terms of if we did these without general anesthesia, I mean, I think that's future studies. That's not something I can answer to right now. In terms of ribs, for the Hope for Liver trial, the histotripsy device that we used was the pre-market device. So it's a little bit different than what will be coming out in the near future. So all of our lesions were subcostal, and that was part of kind of written in the trial. So the ribs, since everything was subcostal, I did not really have to deal with any of the rib issues for this study. The device that I have probably would not have really worked intercostal at this time, but I know that the new device is supposed to deal with those issues, so it's easier to have an intercostal approach.
Can I comment on those
Sure.
things? Yeah. So I, Michelle talked about the clinical experience. So what I would want to add for the breathing issue, I can't talk to the clinical device, but there are papers published. You can it can be checked out where there are actually some pre-modeling done based on, when you have general anesthesia, so the breathing motion is pretty regular. So there's actually treatment planning can be done. If you're targeting, for example, a spherical zone, then in terms of the treatment planning wise, by looking at what shape and the size, how you deliver the treatment, that can be then based on the simulation to define a treatment plan to allow us to uniformly deliver the histotripsy dose to cover the target volume. So you're, with a regular motion. So there's some mathematical modeling that's actually, all that is actually in the papers that's actually already published. So I don't want to talk about the clinical device, but I'm saying that's even though it's not motion tracking, but there's some modeling-based approach to address that. Second, I think in terms of the transcostal treatment or how to deal with ribs, again, we also have papers published. We're showing the pics where we did a treatment using completely subcostal window where we don't have to go through ribs and also going through the ribs and then compare the two. So at least a preclinical pig study, we were able to show, and actually Eli was part of that study too, that showed that the lesion generation, the size, the dimension, shape of the volume of the ablation, there's no significant difference between the subcostal treatment versus actually transcostal treatment. Also, we use a thermocouple to measure the heating on the ribs, and the rib heating was able to maintain the under 4 degrees of temperature increase, which is not sufficient to actually cause thermal damage to the ribs. So it's about, really about what duty cycle, that was used, of course. So that publication, the key is that, subcostal ablation is doable, to keep the same kind of precision. However, the duty cycle needs to be modified to make sure to keep the thermal effect or to keep the heating on the ribs to below the safety region.
Eli, do you want to comment also on that?
Yeah, I agree with Jen. I think we have a lot of data now, especially on the therapy side, that we can treat both subcostal and transcostal. I think the challenges are going to be on the targeting side, particularly with a lot of our more conventional devices have all been driven by ultrasound image guidance, where there's some interesting work out of the University of Wisconsin group now who's partnering with Histosonics, as well as Jen's team, on developing image fusion techniques so we can target with the same precision we get subcostally. So it's less of a problem, I think, the therapy, but making sure we have those image-guided tools to allow us to target them appropriately.
Thank you. Well, now that we have you here, Zen, let's talk about your study. Your study shows a consistent abscopal effect, about 80% in mice. So this is outstanding. And can you describe us how do you achieve that?
So I wonder, so first of all, I want to kind of give more detail of this study. So it is a study done in a rat liver tumor model. So this is a MCA model with spontaneous metastasis. And in this specific model, we get intrahepatic metastasis within about 2 to 3 weeks after tumor implantation. Basically, the liver is pretty much just full of metastasis, and those rats, if not treated, need to be euthanized. And for this particular treatment study we did is at 1 week point after tumor implantation, and this is basically around like the metastasis onset point, so it's a relatively early stage. We are treating them when metastases start to form, but not like multifoci at this point yet. And we treated 11 rats and treated 50 to 75% of the tumor volume. And then in 9 of the 11 rats treated, the residual tumor all gone, and also there's no new metastasis formation. So all those rats had a tumor-free survival, 9 of the 11 of them, until the 3 months study endpoint that we actually euthanize them and get histology to confirm that there's no tumor cells in there. So I do want to, be. So it's great results. We're really, excited about it. But I do want to be cautious about it in a way that one is that it is, treatment occurring at a relatively early tumor stage. So we are actually in the process of performing a study where we are treating at a later stage where we have multifoci metastasis, which is actually really, if you look at the patient population in the Hope for Liver trial, Michelle and others have been treating pretty much, most of the patients enrolled in the trial, they all had multifoci metastasis in the late stage. So I think it's important for us to actually study that, and we don't really have data yet at this point, and we're in the process of trying to get data for that, and to see whether histotripsy treatment alone will be able to actually cause metastasis reduction. There, of course, at that late stage, it's likely that we may have to combine histotripsy with immune therapy drugs, and that's something that we do want to do as a next step. But we don't have any data on that yet. We haven't tried that yet, and I think Kathy has a lot of experience where her group combined. Focus also on treatment with immunotherapy, with primer and different drugs, and those combinational therapy, and that's something that we definitely think we would like to do in the future.
So do you think that this is ready to be transferred into humans, or what else we have to know to transfer it?
I think there's still, I don't think it's ready yet. I do feel there's still, some key information we need to get. First of all, we have some data showing that histotripsy parameters can have a substantial effect on the immune response and the abscopal effect induced. And we have not done a full parameter study to, right now, in the clinical trial, the dose delivery is determined by the safety. We haven't optimized it for abscopal effect yet, and based on our preliminary data, there's a lot, really, there's a room certainly to get a better understanding of what would be the best parameters if that's a goal. And second is that we haven't studied certain clinical factors that can really impact that. Like I said, the tumor stage is a big one, right? Like to understand at different tumor stage, really what's the impact. Something we also want to study is liver disease. How would that impact the treatment outcome? And I think those knowledge and of course, the immune response, immune profiling, which we really think is the underlying mechanism, we also don't have a good understanding at this point yet. So I do feel like we need to get a better understanding and get more knowledge so that we can actually design a trial with the good, maybe not the best, but certainly a consistent parameters that I hope can achieve some abscopal effect even in late-stage patients. And maybe histotripsy alone would not be sufficient in that case, and maybe we have to combine with checkpoint inhibitor therapy. So the combination with the immunotherapy is something I also think is very important to study before we actually go on and design a trial for that.
Do you think that it is important in this lysate of when you destroy the tumor that there are normal tissue, for instance, that there is a role of the tumor margin there?
Yeah, so I think that we, even though our paper that published, we're doing partial ablation. And we were treating only part of the tumor, and then that actually the reason the study was designed that way is because we were treating relatively early stage tumor, so we didn't want to treat the entire tumor. We want to treat some of the tumor and have some left to see the effect. But for the late stage treatment that we are doing right now, the study where we actually have multifoci metastasis already occurring in the rat liver, and for the targeting tumor, we are trying to treat the entirety of the liver, not just a portion of it, and seeing then we will observe the effects. So I don't have the data, at this point, I don't have the results to really answer the question, but we are in the process of collecting data to see if the complete tumor treatment will also lead to abscopal effect, or is it better or worse than the partial treatment? We'll have data in the near future to answer that question.
Thank you. Kathy, what do you think on this? What's your ideas or improve more this percentage and arrive to 90–95% of this abscopal effect?
Yeah, first, it's very exciting. It's great to hear the progress that's been made in terms of translating histotripsy, both in the preclinical and clinical arena. It's really exciting and great to see. I think there's a tremendous amount, if it turns out that an additional immunotherapy component is needed, there probably is more space for innovation even in the liver than in other organs, I guess I would say. So, everything that you can think of in terms of using checkpoint or using an adjuvant, you could do in the liver as well. The big difference is that so much of the dose of what we would give as an antibody or as a nanoparticle ends up in the liver anyway. And so, if what you're trying to do with ultrasound and some additional drug is important to get regionally around a region of disease, given that you have so much drug there, you have different opportunities than you have, say, in other organs, I think. So, it is, I think that if you do find that you need different, or some additional effect, there definitely are possibilities. So we've looked at, other work that we've done that's not thermal ablation. We've looked at using microbubbles and plasmids, for example, to transfect regions to have an anti-tumor effect, so that cells would or even tumor cells would act as a source for to draw immune cells towards themselves. That kind of work is, could be easier to do in the liver. Also, we also look at, for gene delivery, we look at adeno-associated viruses. And we just had a paper where we looked at the trafficking of those in the liver and demonstrated that with different capsids, you would see capsids travel to different cells within the liver and they would transfect a different fraction of the liver in those cases. So I think that there's a lot of knowledge there in terms of modified capsids that can transfect different cell types in the liver. So I think there's a big space that could be opened if it turns out that the effects that you're seeing are not sufficient and you need to add an additional drug or immune component or even transfective component in the liver.
Thank you, Eli. Let's move to other type of different tumor types. So you've done different work with histotripsy in cholangiocarcinomas, liver metastases, hepatocellular carcinomas, cirrhotic livers. So what can you tell us about that?
Yeah, I think some of this, it's interesting to hear Jen's recent results talking about what's the proper dose for inducing abscopal effects, because we've really looked at, if you look at what the treatment doses are in the clinical trial, they're set so that they can treat all of these liver tumors. And we've looked at that from a primary ablation standpoint. But we recently did a series of studies on ex vivo human tumor samples as well as in vivo, first with the goal of testing the feasibility, could we treat cholangiocarcinoma tumors? So they offer a unique challenge because they're highly fibrous, the mechanical properties are stronger, and typically histotripsy struggles to ablate those type of tissues, and this is why we have such unique tissue selective effects where we can ablate softer tissues while preserving vessels and bile ducts. So we wanted to see, can we treat cholangiocarcinoma tumors? And we were able to publish both in vivo as well as ex vivo with human samples that we were able to get still high precision complete ablation of the cholangiocarcinoma. However, the tumors would take at least 4 times the treatment dose or higher in order to treat, compared to what you would have with liver mets. And then we also compared to HCC tumors, which were about an order of magnitude lower dose even than that. So the fact that in the clinical trial we're seeing all of these tumor types are able to be ablated, I think to me suggests that we're significantly over-treating primary HCC as well as liver mets. So those, from a treatment standpoint, I think that's going to be allow us to have faster treatment times when we optimize these parameters for larger volumes of ablation. It'll be interesting to see where that optimization point is between ensuring we get complete tumor ablation, if that remains the goal, but also optimizing abscopal effects and the immune profiling. I would say the final aspect of that we are very interested in is if we treat a more fibrous tumor like a cholangiocarcinoma, are we going to still be able to maintain the tissue selective features of that? So we've recently been doing a study that's comparing basically all the critical structures we're interested in, nerve, bile ducts, vessels, stomach, different types of bowel, and looking at, in a worst case scenario, if we actually generate histotripsy in these organs and try to ablate them, what's the differential dose? And we've seen that, again, there's a higher threshold for ablating the different tumor types, but for our main critical structures, particularly vessels and bile ducts, the vessels have the highest dose that even compared to the cholangios, we still have that safety margin, as well as bile ducts. When we get to things like the gallbladder and stomach, it's closer in dose to what we see for, let's say, the cholangiocarcinoma dose. So I think those are gonna, if you wanna treat like we are now, where vessels can run right through the tumor or bile ducts, I think if you start looking at locations where it's right by the stomach or right by, let's say you have a cholangial tumor right on the gallbladder, we're going to have to be a little more careful about how we optimize those parameters in order to maintain the tissue selectivity, or maybe we're less aggressive on that boundary and aren't relying on the tissue selective aspects, but instead are doing more treatment planning and using the image-guided precision in order to avoid those.
So you're saying that we have to be very cautious in treating tumors closest to the capsula, to the liver capsula that is close to the stomach?
I think if it's if your ablation is going into the stomach, I think particularly if it's one of them, a liver met or a cholangio, and you're driving the transducer harder to ensure complete ablation. I think less so for HCC. But the capsule is interesting because originally that was a worry of ours, and we've seen more recently that the capsule itself is very resistant to hystripsy damage. We haven't included that as a separate dose study, but we now have evidence that tumors that are into the capsule or even going through to 2 lobes of the liver, we've been able to ablate those while maintaining the capsule itself. So I think that the capsule is not as much of a problem as, you know, what the size of our focal area is and if we're directly targeting those, you know, structures that are nearby.
Michelle, in your trial, there was no requirements to treat tumors that were close to the capsula. Did you have to deal with that?
Yeah, in fact, because of the location being subcostal, you know, the limited location, we did have lesions that were, you know, segment 3, segment 6, 4B that were on the capsule, and we did successfully treat them, had a handful of them. So we didn't have any issues treating them in terms of pain related to capsular pain, rupture of any capsule or tumor. We had good, well, our results thus far have been positive without any safety concerns treating subcapsular lesions.
And then what about the issue of the portal vein thrombosis? Do you think that this is a major contraindication or not?
So in terms of portal vein thrombosis, you know, there was a pig study that came out of Wisconsin where they showed portal vein thrombosis in some of the pigs that were treated, which resolved over time without any lasting effects on the liver, such as any sort of overlying parenchymal atrophy, perfusional changes that lasted. You know, the thrombus resolved and imaging looked great afterwards. In terms of, again, our data with this trial, I can't say too much, but I can say that we did see clinically irrelevant portal vein thrombosis in a couple of the cases. There was no clinical effect on the patient. 1 month later, no lasting effects in terms, from an imaging perspective, in terms of any sort of perfusional changes, any sort of parenchymal atrophy, you know, from long-term portal vein thrombosis. So I think it's something that's quite transient. And thus far, in our limited studies, we don't see there being any sort of clinical relevance where we've had to put them on any sort of anticoagulant therapy or anything. We have not had to.
Kathy, do you have any experience on that? What's your idea on portal vein thrombosis?
Yeah, sorry, I don't have any experience in that in terms of whether it would be an issue.
And Sen?
Well, we actually, I will actually say the kind of the different thing where we initially had more concern about histotripsy as a mechanical approach will cause more bleeding rather than thrombosis. So we actually in the past were conducting studies specifically where we actually even inject heparin into the pigs and then do the histotripsy study to see if it will cause significant bleeding. And we didn't, and it was interesting where we actually, even in the, and that's actually also the study I think Eli did where the pig was heparin injected. We did not even in those animals see excessive bleeding post-treatment. I think the thrombosis of the vessel in the animals, in our experience, at least in the animals, we didn't see any long-lasting effects.
Eli?
Yeah, I agree. I think they cited the main papers we've done on this, and there's some, you know, monitoring that you're going to want to have with that and follow up to make sure that the clotting that shows up acutely, particularly when we're treating a tumor around a major vessel, we see, I think, fairly consistently in that case that we're going to get some, you know, acute 1 week clotting, and then it seems to always clear. But I think it should be something that's mentioned and monitored for post-procedures.
Thank you. We have less than 5 minutes. There is no questions from the internet, and if anyone from the floor wants to have a question, the floor is open. If not, well, to all of us, to all of you, in looking at the current situation, do you think that it will be best to treat all the lesions in the liver, in a setting of a patient with multiple liver metastases, treating all them, treating partial lesions of them, make combination of other therapies. What would be the best option to get this abscopal effect to obtain the maximum tumor control? Eli?
I guess I can go first, and I'll defer to Jen and Michelle on the clinical side, what they've seen with histotripsy. I think the question about timing is one I'd want to bring up. So one of the studies we'd like to do next is how much volume of ablation in a single setting, right? So whether you're targeting them all at once, I think is a separate question than whether we need to go after them all. I'm very excited about the data, but I tend to still lean towards let's try to treat them all and not rely on the immune response or the abscopal effects to do that until we have more data to suggest that. But I do think this question about as we move towards beyond the 3 centimeter tumors limit that's in that Hope for Liver trial, can we treat 4 or 5 centimeter diameter tumors? We have plans to open a canine clinical trial for treating up to 8 to 10 centimeters, and we want to basically ramp up the treatment volume to see what's a safe total volume within a single session. I'm very interested in seeing if those repeated treatments also have some kind of repeated immune stimulating benefits. So I don't know if that's something that Jen has started to look at in the small animal models or if others have different thoughts.
Jen.
Yeah, so I really think this question may depend on the stage of the tumor, and depending on the patient. So I think if the tumor at the time of treatment is at maybe relatively early stage or even intermediate stage, where ablation it's possible to use ablation to actually treat the tumor, and we have shown that we can safely ablate them. Then I do feel like maybe that should be the way to go, although I concur with Eli that we don't have enough knowledge at this point as what's the largest tumor we can treat in one session safely without causing any clinically significant side effects. So it's possible that similar to radiation therapy, maybe for patients with really big tumors or multiple tumors, well, we do want to treat them with ablation. We may have to do multiple treatments, fractionations. But in terms of late stage patients, where I have had the opportunity to see the patients at Michelle treat, and some those patients, and I think Ron, you have treated patients where they're the tumor, there's just so many tumors. Right, the liver of the patient look like sweet cheese, basically, and in those patients, I don't think it's even possible to just do ablation, to trying to treat every single one of them. There's just way too many. For those late stage patients, I think we have to leverage the abscopal effect induced by histotripsy, and for how was the best to do, whether to treat 1 or 2 or 3, and combine with immunotherapy, and maybe we need multiple administration timing and all those. Again, I think we are at really early stage to just start seeing some promise, but we don't have enough knowledge to really answer that question yet. And I'm hoping we are, really doing all the studies that we're doing now and the cumulative knowledge that allow us to be able to design some trial that leveraging this immune stimulation effects in the patients so that we can get closer and closer to really finally address that question. I do think for late stage patients where you have so many metastasis nodules that we will probably need a combination therapy where we combine, for example, histotripsy with immunotherapy, some sort of combination therapy. And yeah, we need to learn more.
Thank you. Kathy, your thoughts on that?
Yes, I agree. I think you're saying that there are definitely going to be cases where it's not practical to treat the entire liver disease, so with ablation. So learning what you can and being able to couple that with other therapies is going to be important in the future, at least in a subset of patients.
Thank you. Well, I think we're running out of time. I want to thank you for this short panel on liver, but I think we answered very interesting questions. I remember when I was in my fellowship years of surgical oncology here in Washington, D.C. with Paul Sugar-Baker, we were doing a technique that was called the Swiss cheese technique. So we would be doing metastasectomies, I mean, in open surgery. So I don't know if this is our way in focused ultrasound ablation, but it will be very interesting. It will be a joke of the destiny. So, well, thank you again. Thank you all the floor for being with us at this moment. You can stretch again because this is continuing. Now I think it's coming prostate. So thank you, panelists. Thank you, floor. And see you next time.